All right. So when we do cardiac cath and cardiac intervention, we mentioned two access. You can do the femoral approach or the radial approach. It doesn't matter. There's a push now, or more people are going on to the radial approach because it is less traumatic for the patient. You have less vascular problems. It's a learning curve. Um, it's I don't want to say it's not user friendly, but there's a learning curve. You have to do a number of radial approach to get to a certain comfort level. But it doesn't matter. Essentially, uh, you're gonna cannulate the blood vessels around the heart, and you're gonna look at the blood vessels around the heart. That is the basic, uh, you know, that's the basic approach. You have to get to the coronary vessels and then look at the coronary vessels to see if they're occluded, yes or no, because your angina or angina equivalence or your heart attack is due to blockage of the blood vessels around the heart. So you basically want to look at the blood vessels around the heart and determine if they're normal, and if they're not normal, then where the blockage is located, how significant blockages are, and then what approach. Are you going to use medicine, or are you going to do a balloon angioplasty and a stent, or does the patient need bypass surgery? So those are questions that you can answer after you do your cardiac cath procedure or your angiogram. So, you know, say we use a femoral or radial approach and we get to the coronary vessels. Remember that the coronary arteries comes off the coronary cusp. So the right coronary artery comes off the right coronary cusp, and the left main coronary artery comes from the left main uh, coronary from the left coronary cusp. Also, you have to remember your anatomy, the vascular anatomy. Remember the left main, which comes from the left coronary cusp, divides into a left anterior descending coronary artery, which comes in the front of the heart, and it loops around the apex. So it's the LAD which loops around the apex of the heart. And then you're going to get what we call septal branches, and you're going to get diagonal branches. So the LAD is going to give off branches. Uh, we had mentioned the left main divides into a left anterior descending coronary artery and left circumflex. The left circumflex loops around the back of the heart, and that will give off what we call obtuse marginal branches. And then on the right side, from the right coronary cusp, you're going to get the right coronary artery, which also gives off branches. So you need to know your anatomy. So when we do our angiogram, so we go up and we cannulate. So this is the right coronary artery. So you can see our catheter. So this is a femoral approach. We went from the femoral artery, we went up into the aorta, the aortic arch, and the ascending aorta, and then we get to the cusp, the coronary cusp. We To get the right coronary artery, we cannulate. We get to the right coronary cusp and then cannulate the right coronary artery. And what we do, we just inject dye. So we inject contrast material and take what we call cine angiograms. And then, so you get pictures of the right coronary artery. And so the right coronary artery, typically looks like this. You want to see a nice smooth vessel. This vessel has no blockage. Ideally, you want to take a couple views. Here's something I want you guys to look at. Look down the bottom here, okay? If you look at the bottom, you'll see 37.11 LAO. LAO mean left anterior oblique. So the camera is on the left, it's anterior, and it's oblique. Okay, so it's tilted, and it's tilted at 37 degrees roughly. Okay, so it's anterior oblique, so it's on the left side, tilted about 37 degrees. And then if you look right here, it says caudal. It's a caudal 6.0, roughly 6 degrees. Caudal mean the camera is tilted to the legs. If cranial mean it's tilted to the head, caudal mean it's tilted to the legs. Okay, so you have to understand those jargons. Um, it's it's very important to know the what we call the coordinates, because if this patient had an obstruction, a lesion in this coronary artery, and this is the view that shows it best. You wanna get to these coordinates again so that you can approach the vessel, put in use your balloon, open the vessel, or put a stent in. Okay, so this is the right coronary artery, and this is what you want to see: nice smooth tube, no blockage. Okay, so when we inject the dye, remember the heart is moving. So when you do your study, you're talking about a moving. You can see that the heart is moving. Okay. Where you inject your dye, you see there's no obstruction, and then you wanna take another view. So if you look here, we this is RAO now, RAO caudal. So your camera is now on the right side at 30 degrees, and it's towards the leg. Okay, caudal mean towards the legs. So you inject the dye and you outline the blood vessel. So okay, so there's no, you can see that there's no obstruction. Nice tube, clean. Okay, so that's the right coronary artery. I personally take at least two views. I will do two views if it's normal, and then, for the right coronary artery, I'll do two views, and then that's it. Then I go to the left side. Remember, the left main coronary artery comes from the left coronary cusp. And the thing about again, the left main divides into a left anterior descending coronary artery and a left circumflex coronary artery. So if you look here, you can see the coordinates that we use. Left anterior oblique, 21 degrees. So it's just on the left side. The camera is tilted 21 degrees to the left. And then you can see cranial. So it's tilted to the head. So it's on the left side. It's tilted. It's up, you put it towards the head at 15 degrees roughly. And the important thing to note is that with these coordinates, the left main coronary artery is right here, and then it splits into a LAD, left anterior descending coronary artery. So the LAD is going to be the vessel that runs like straight down. So this is the spine. You can see the spine in the picture. Okay. So the left main coronary artery it splits into the left anterior descending coronary artery, which comes straight down. Remember, the left anterior descending coronary artery is the vessel that's going to loops around the apex of the heart. So it's important to know that. And then the left anterior descending coronary artery is going to divide into septal branches and diagonal branches. Now the blood vessel that loops around the back of the heart is the left circumflex. So the left main coronary artery divides into LAD, left anterior descending coronary artery, and a left circumflex, which is right there. So let's play it, and again, we just inject contrast, and it outlines the blood vessel. So you're looking for obstruction, okay? You have to get multiple views as well, all right? So it's another view, and these are the coordinates for this view, okay? RAO cranial. So the number denotes the degrees. So it's RAO cranial. So it's on the right side, tilted at 21 degrees, and it's towards the head. Okay. So um, let's play that again. So the left main coronary artery is right there. This vessel now is, so again, the left main is going to divide into a circumflex and a LAD, okay? So this is going to be your LAD. The LAD is the vessel that loops around the apex of the heart. It comes in the front of the heart and loops down goes towards the apex. And then the circumflex is going to be right there. So it's important to properly identify your blood vessels, because you need to know which vessel is occluded, or where the pathology lies. So again, this is another view, and if you look here, you can see the coordinates. RAO 24 degrees, so it's on the right side. The camera is tilted 24 degrees on the right side, but it's caudal, it's towards the leg. Okay, so it's towards the leg. Again, the left main coronary artery, which comes from the left coronary sinus or left cusp. So the left main is right there. The catheter is in the left main. This vessel now is the left circumflex. Okay, this is the left circumflex with your obtuse marginal branches, and then this is the LAD, which comes straight down and then it loops around the apex of the heart. So let's play it. Okay, so all you do, you inject contrast material in the vessel and look at the blood vessel. Okay, so circumflex and the LAD. All right, so again, the left main splits into a left circumflex and the LAD. So this one is the circumflex, this is the LAD. LAD is the one that usually loops around the apex of the heart. And then again, you're going to get multiple views. This is what we call the spider view. Okay, you can see the coordinates for this. It's LAO, so it's on the left side, it's oblique at 23 degrees, and it's caudal towards the leg. And then all you do, you inject your dye, you take your images. So this one is going to be the circumflex over here, and the LAD is right there. Remember, the left main coronary artery is going to, so this is your left main, and it splits. This is the left main coronary artery, circumflex LAD. All right. So you need to know what the normal blood vessel looks like, because if you have occlusion, you need to know what the occlusions look like. So, all right. So those are the vessels. So we also in when we do a cardiac cath, we also try to get the ejection fraction. So we get ejection fraction when we do echo. We try to get an ejection fraction when we do cardiac catheterization as well. And how we do that, we put the we put the catheter, the pigtail catheter, we put that into the left ventricle and we inject dye and we see how the heart pumps it out. So this is what that looks like. So you can see the pigtail catheter. All right, so again, this is a femoral approach. So we come up the descending aorta. We come to the aortic arch. We come down the ascending aorta, and we go across the aortic valve, and the catheter is in the left ventricle. And we inject dye into the left ventricle and just see how well the heart pumps it out. And we can determine the ejection fraction like that. So pigtail catheter because we want to minimize or eliminate trauma to the left ventricle. So that's why we use a curved catheter. All right, you can see when we inject the dye in, we can see how the heart pumps it out. So the heart the contractility of the heart is normal, very normal, because it almost come all the way in. It pumps the dye out um, very efficiently. So you from doing your this is what we call a left ventriculography. By doing your left ventriculography, you can get an idea of the ejection fraction, wall motion abnormality if it exists. Again, you use specific coordinates for this. The best view to or the recommended view for your left ventriculography is about 30 degrees RAO. Okay, so you can see the coordinates down here. We use 31 RAO, right anterior oblique. So the camera is tilted to the right side at 31 degrees, and there's a caudal of 2 degrees. You can, uh, uh, we can eliminate the caudal angulation. A lot of time we'll just have 0 degrees because we're not going to tilt it to the head or to the legs. Okay, so again, your pigtail catheter in the LV, and you just want to see how well the heart pumps the contrast material out. And from that, you can get an idea of ejection fraction. Also, if the patient have mitral regurgitation, you can see there's a little blood going back across the mitral valve. So you can see that there's some mitral regurgitation. So, and you can quantify the mitral regurgitation as well. So if you look closely, when if you look closely, you can see that there's some contrast material. So you inject the dye, you can see there's a little dye going back. So it's going across the mitral valve into the left atrium. So there's a little bit of mitral regurgitation there. Okay, so that's a normal. This is another femoral approach, and so again, you whether you use the femoral or the radial approach, the idea is to get to the coronary vessels, inject your dye, and have a look at the vessel to see if there is any occlusion, any pathology in the blood vessel. You need to have a routine or a protocol. I normally start with the right coronary artery, then move to the left, and then I'll do the left ventriculography last. Okay? Again, look at your coordinates. Okay? I usually start on the left side, then move the camera to the right. Cranial first, and then caudal. So it's just a protocol, a standard that I do. So the first view, you can see it's LAO, left anterior oblique, 36 degrees. So the camera is on the left side, 36 degrees, more towards the head. Well, there's almost no cranial, so it's 0.55 degrees. So it's almost straightforward LAO, just in the left. So inject so this is the catheter in the blood vessel, and this is another nice smooth blood vessel. You don't see any obstruction. Very important, however, is to have an idea of size. Have an idea of size. Now, this is a right Judkins catheter, and the size of this catheter is 2 millimeters. The size of the catheter is 2 millimeters. This is a right Judkins catheter, size 2 millimeters. So from that, you can judge the diameter of the blood vessel. So this blood vessel is, probably 1.5 times the catheter. So we say that that's probably about a 3.5 millimeter blood vessel. All right. So if we were going to use a balloon or a stent, we need to have an idea of the size of the vessel, because we're going to use that size stent to stent the blood vessel. You don't want to use a larger balloon or stent, okay, you can rupture the blood vessel, or you don't want to use a smaller balloon or stent. You want to use just the right size. So again, when you cannulate the right coronary artery, I usually look at least two views. If it's looking normal, a minimum of two views I would image. If it's abnormal, then I'll probably do more. So again, you inject the dye in the blood vessel, you take the pictures, and you can just see what the blood vessel looks like. So this is another view of the right coronary artery. So you inject your dye and you look, because sometimes you might have an obstruction, a lesion that is what we call eccentric. So in one view, it may look completely normal, and then in another view, you can see it. So, you should multiple views. All right. So this is the left system now. Okay. So again, the left main is going to divide into a left anterior descending coronary artery and a left circumflex. That's the usual anatomy. So this is your left main, and with this view, this is your LAO cranial view. So LAO, the left anterior oblique, 22.7 degrees, so it's tilted to the left, but it's more towards the head. Okay, about 25 degrees. And in this view, this is the left main, and the left main divides the LAD. The LAD is going to run down the spine like that, and then the circumflex is the one that's going to go towards the sides. So you just inject your dye, take pictures, and you look at the blood vessels. Okay, so you need to know what the normal vessels look like. Nice, smooth vessel. Okay, so this is another view. Again, remember the LAD is the one that loops around the apex of the heart. Okay, the left anterior descending coronary is the blood vessel that usually loops around the apex of the heart. The apex of the heart is down here. So, this one is the LAD because it comes down to the apex. Okay, again, look at your coordinates. The coordinates is RAO, right anterior oblique, 29 degrees, and there's a cranial angulation on that. Okay, this is your circumflex right here, and it gives off the obtuse marginal branch. The LAD loops around the apex of the heart. Okay, it's another view. So this is the circumflex here, and these are the obtuse marginal branches. The LAD is the one that comes in the front of the heart and loops around the apex. So this is your LAD, because it's going to, remember, the left anterior descending coronary artery is going to give off septal branches and diagonal branches. Okay, so you're going to take multiple views because, so this is this is our spider view, and this is the coordinates that we use. It's LAO, so it's left anterior oblique at about 3 degrees, but it's towards the legs. Okay, caudal 37 degrees. It tilted towards the legs, and spider because it's the vessels are splayed out. Again, this is the left circumflex, and the LAD is over here. Okay, spider view. But the most important thing is to look at the coordinates that you use to get the views. All right, so again, the circumflex is there, the LADs over there. This blood, the short vessel here is the left main because the left main coronary artery splits to give you the circumflex. It splits to give you the sorry, left main is right there, give you the circumflex and the LAD. So you look at the vessels and you determine, is the vessel small, is it medium, or is it large? And then if is there any obstruction. So this is another spider view. You can see the vessel splays out. Okay, the left main is here, the left circumflex, the LAD is over there. Okay. All right, and then of course again my protocol is the right coronary arteries, 2 views if it's normal, more views if it's abnormal. Then I move to the left side, then I'll do minimum of 4 views if it's normal. If it's abnormal, then more than 4 views. And then the left ventriculography, where the catheter, the pigtail catheter, is positioned into the left ventricle. Okay, so you can see the pigtail catheter right there. Okay, so it's a curved catheter because if it was a straight catheter and you're going to power inject, so we have a specialized injector that inject the dye under tremendous force. So if you had a straight catheter, the catheter could just spear the left ventricle and traumatize the left ventricle. So you use a curved catheter instead. Okay. So with the catheter in the LV, you just inject the dye, and then the LV will pump the dye out, and you can determine the ejection fraction. So this is fairly decent. You inject your dye, and you see how well the LV pumps the dye out. Okay. It doesn't appear to be any significant mitral regurgitation. Okay, so this is the left ventriculography, and this is the coordinates we use. Uh, Roughly, it should be about 30 degrees RAO with no cranial or caudal angulation. This these coordinates, however, or this coordinate, however, is 34 degrees RAO, right anterior oblique, and there is a little cranial angulation there, about 4 degrees. So this is another normal study. Again, you need to know what the normal studies look like so that when you have an abnormality, you can pick it up right away. All right, so again, you know, I'm doing more radial approach now, so you're not gonna see your catheter coming up like this. The catheter is gonna come from the upper extremity, usually the right side. So, you know, going forward, we're gonna be doing more radial approach. Again, the reason for the radial approach, the vascular complication is less, and not whenever you get vascular complication, it's usually not life threatening. When we go to the femoral artery, you can have real serious vascular complications. So that's one of the main reason. And then the other reason is the discomfort to the patient. Radial approach, when we do the radial approach, um, there's less discomfort. The patient can walk around as opposed to when you do the femoral approach. Uh, the patient has to lie flat for a few hours. They can't move, and then you're going to limit their walking because you don't want, if you use a plug angioseal, you don't want them to dislodge it, and they can get bleeding, hematoma. So with a radial approach, you can get them up and walking uh, readily, and you can discharge them from the hospital in a very short time. So we we are moving towards more radial approach. So again, catheter in the right coronary artery, and you inject your dye, take pictures. So you need to observe closely what's happening here. Um, you have to observe everything. If you look here, remember we said the size of this catheter is about 2 millimeters. This right coronary artery is small, it's tiny. The proximal portion is probably similar to the size of the catheter, but it tapers down. So this blood vessel is probably 1.5 millimeters. It's a very small blood vessel. So if there was a lesion here, we'd probably not do anything, because if we do anything to try and fix it, we may cause more harm than good. So, it's a very small blood vessel. It looks normal in terms of no obstruction, but it's just small, it's tiny. And, you can see when you do catheterization, you're going to see all different sizes of vessels. Some vessels are of big, some vessels are medium size, and some vessels are usually huge. Again, I usually take at least 2 views to make sure that there is no lesions. So the vessel is just tiny. I don't see any obstructive lesion. You can see branches coming off. And then per my protocol, then I move from the right coronary artery now to the left. So the catheter is positioned into the left coronary sinus. You cannulate the left main coronary artery and you inject that. So, so, all right, so it's a left Judkins catheter. For the right, usually use the right Judkins catheter. For the left, I usually use the left Judkins catheter. So this is your left main that comes here. It's split. The LAD is going to come straight down, and the circumflex is this one. So again, the size of your catheter is about 2 millimeters, so you can judge the size of the vessel, uh, you know, from that. You can see that the left system is much bigger than what was on the right side for this patient. So this vessel is probably, especially if you're looking in the LAD, it's probably a 3 millimeter. It tapers down a bit, but the mid and proximal portion, the mid is probably about 2.5, 3, and the proximal is definitely a bit larger. So if you had to put a stent or use a balloon, you can judge the size of the stent of the balloon by just looking at the blood vessel. Say multiple views. Again, look at the coordinates. So the camera here is on the right side towards the head. And then, so this is the left main coronary artery, the left circumflex is right there. And then your LAD comes here and it loops around the apex of the heart. Okay? So, you inject your dye and you look at the vessels, you're looking for blockages. Okay? So remember, the heart is moving when you're doing your work. So you're going to see the heart moving. All right. So the left, the circumflex and the LAD. Okay. And then and its branches. So your left main coronary artery is right there, left circumflex, and then these branches are your obtuse marginal branches. This is the left anterior descending coronary artery that comes, it loops around the apex of the heart. You're going to get septal and diagonal branches from the LAD. Okay. So this is what, yes, a fairly normal blood vessel, no significant obstruction. Okay, this is this is our spider view. Okay, so you want to splay the blood vessels out so you can look to see if there's any obstruction. All right, so spider view. So this is the left main coronary artery. This is your left circumflex, which is with its branches. This is the left anterior descending coronary artery with its branches. Okay, and again, you can see the proximal portion of the vessel very well, and the mid and distal as well, but the proximal portion of the vessels you can see very, very clearly. There's a spider view again with circumflex here, LAD over there. Okay. And then per my protocol, I move on next to the left ventriculography. Pigtail catheters in the LV, and you just inject dye and look how well the heart pumps the blood out. So you can see that this patient have mitral regurgitation. Look here. When the LV pumps the dye, you can see dye going back over here. So that's because mitral regurgitation. Let's look at it again. So when the LV pumps the dye, you're going to see dye going back into the left atrium. Okay? So you can have an idea of the ejection fraction and see if there's any mitral regurgitation. All right, let's look again. Okay, so if if you look closely, you can see dye going back over here. That's because the LV is pumping the contrast or the dye across the mitral valve and into the left atrium. And that's the definition of mitral regurgitation. So just look closely. You can see that contrast is going to come back. You see some contrast over here. That's because you get the patient have mitral regurgitation. So blood is moving from the LV across the mitral valve into the left atrium. So let's look again. So catheter, pigtail catheter in the LV, and you can see the LV is contracting. You can see contrast coming back there. So, and we can determine the severity of the mitral regurgitation. There are methods that we can use to determine the severity of the mitral regurgitation. So, approach. So, for the next case, there's some pathology, and we're gonna look at the pathology, but the protocol is basically the same. You know, you need to have a protocol, stick to the protocol. Um, so let's look. So again, usually start with the right coronary artery, and so you can see that this is not looking like what you have seen. So there's a lot of irregularity there. Okay, so you might want to do more than your two standard views. there's a lot of irregularity in these blood vessels, in this blood vessel. Um, Again, the catheter is about 2 millimeters, and if you look at the blood vessel, it's about the same size, so probably a little bit bigger. But there are lesions. There's something in the proximal vessel, the mid vessel, and in the distal vessel. So, another view, if you look, so this is the proximal portion of the vessel. It's lumpy, bumpy, the mid portion, and then when you look here, you see a significant narrowing in the mid portion. The distal vessel doesn't look too bad, but just look at the mid portion. There is probably a significant lesion right there. The vessel is not very large. It's about the same size as the catheter, so probably 2 millimeters. All right, let's look at another view. So this is another view. Uh, you can see lumpy, bumpy, not a nice, straightforward vessel. Uh, but we did see something in the mid portion of the vessel. And then, so we move our attention now to the left side. Again, the left main LAD is going to come down here, and the circumflex is going to be over here. You need to note the coordinates, LAO cranial and the angulation that we use. All right, so if you look at the blood vessel, so again, lumpy, bumpy, there are probably some blockages, you know, look at the vessel. So you need to have a close look at the vessel, especially on the circumflex is lumpy, bumpy stuff. This is the LAD that comes here. Remember, LAD is the one that loops around the apex of the heart. So we take another view because, especially when you have blockage, you have to do multiple view, lest you will miss significant blockage. And if you look closely at this blood vessel, there's a significant lesion here, and if you don't pay attention, you'll miss it. So let's look. Okay, so okay. If you look closely at this point, you have to look closely at this point. There's a significant blockage. This is the LAD, and there's a significant blockage in the mid portion of the LAD. So you look closely at it, you can see, look at it, there's a significant blockage right there. So you want to cone in on that lesion and determine how significant it is. Just look right there. You can see, look at it. You can see a significant blockage. So we want to look at that. So again, multiple views because you want to accurately depict what's going on. So again, see it right there. So in this view, you can see clearly. You can see this is a significant blockage in the LAD. Okay. Remember, we talked about atherosclerotic plaque. We went over that. We went over how they're formed. So see, there's a significant lesion right there in the LAD. Also in the circumflex, there are multiple lesions in the circumflex. So let's look at the circumflexes again. But there's a lesion there. There are a couple lesions right there. So there are significant blockage. So if you were going to do bypass in this patient, you want to bypass the obstruction. So the obstruction is right there. So you'll put your graft distal to the obstruction because this obstruction is going to prevent blood from flowing to the muscles down here. So when you do your graft, you're going to put it distal to the obstruction so that you get blood flow down here. Okay? All right. And then again, these are obstruction lesions in the circumflex. You can see there's also one up there as well. Um, so let's play this. Okay, so but this is very, this is probably 80, 85, 90% occlusion in the LAD. So another view again, you can see it's very tight. It's probably 90%. Okay, so this is the LAD. It's fairly high up. So if that goes, the patient probably goes too. All right, so you can see significant blockage. So if this blood vessel completely closes off from here, all the muscle down here is in jeopardy. And you know, if that happens, usually the patient will probably succumb to the heart attack. Um, and then take another view. Okay, that's our spider view, which wasn't all that great. Um, this is a left lateral view. It's a so-called left lateral. The camera is almost 90 degrees lateral, and then you basically want to see the LAD. And this is a circumflex over here. It wasn't you can see the LAD loops around the apex of the heart. This wasn't particularly a great view. And then the left ventricle catheter in the LV, you inject your dye, see how well the heart is going to pump the dye out, see if there's any mitral regurgitation. So, so the ejection fraction of this patient was fairly decent. There was no significant mitral regurgitation. This is a patient that we actually sent off to bypass surgery because, he had multiple lesions in the circumflex. He had the lesion on the right side. Yeah, the mid LAD lesion. So we actually sent this patient to bypass surgery. Um, again, same protocol. Look at the right side of the heart. Okay, so catheter in the right coronary artery inject. See this vessel is not very smooth, a little bit lumpy, bumpy, but I don't see any significant lesion there. So let's look again. You know, so you want to do multiple views to make sure you're not missing any significant obstruction. All right, let's look again. There's nothing significant. There's little something right there, but it's not any significant lesion. You don't need to do any intervention such as balloon or stenting. So we actually did 3 views because we have to so there's some lesion right there, probably 50-60%. Um, okay, then we'll move on now to the left side. Again, your left main LAD comes down, and then the circumflex. Okay, you can see the blood vessels on the left side are much larger. Um, Again, the size of the catheter is about 2 millimeters, so you can judge the size of the blood vessel. Okay, so circumflex LAD over there, you can see the circumflex is fairly huge. No significant lesions. You look again, circumflex is right there. Some lumpy, bumpy stuff, obtuse marginal branch. LAD, let's look at the LAD there. Maybe that's the LAD comes right here. As a matter of fact, I think the LAD is, you see there's a ghost vessel here. So the LAD is occluded proximally. The LAD is blocked proximally. Okay? So if you look closely, the LAD is supposed to come down here. See? So there's a proximal to mid occlusion of the left anterior descending coronary artery. Okay, so this is actually the diagonal branch that we're seeing of the LAD. Let's look again. So the LAD is supposed to come right here. See? So it's a ghost of a vessel. So these are the diagonal branches. So by knowing the course of the vessel, you can determine what's going on. So it's a little something there in the mid circumflex. So again, the LAD is supposed to come down here. So you see there's a paucity of vessels here. Okay. Something in the mid circ. Then when you look again, another view, so-called spider view, the LAD is supposed to come right there and come down here. So you can see the diagonal branch, but you're not seeing the LAD. Okay, so you can see the circumflex is good, the LAD, we're not seeing that. Alright, so this guy has something in the right, a little bit of stuff in the circumflex, but a lot of stuff in the LAD. LAD is completely occluded. And so this is, the LAD is supposed to come down there. So this is what we call, this is our left lateral view, okay? So-called left lateral view. So the LAD is supposed to come down here. You can see it's occluded from way up there. So the LAD is occluded from proximally. The circumflex is okay. So all right, so the LAD is occluded, and then we do the left ventriculography. Look, so the catheter's in the LV. Look, that ejection fraction is reduced. The heart is not pumping the dye out. Okay, so the heart is not pumping the dye out. So ejection fraction is probably 20% because the heart is not pumping the dye out, and you can see that there's some mitral regurgitation as well. Okay, so this is a patient we elected to treat medically for a number of reasons. The LAD occlusion was somewhat chronic. The LAD occlusion was somewhat chronic, and the ejection fraction was pretty poor. So we treated the patient medically. Another approach, we could have done viability study. So we could have done viability study, and if the viability study was good, then we could go on to do bypass surgery. So that's that. So this patient went on for medical therapy. All right. So